So in today's lecture, we're going to look at a little bit more advanced topics in opioid pharmacology. Here are your learning objectives. Realize that opioid drugs can be divided into three classes, which are the natural alkaloids, morphine and codeine, as well as the semi-synthetic compounds, heroin, and the synthetic drugs, fentanyl and methadone. Understand that fentanyl is about 10 times more potent than morphine, and interestingly enough, morphine, was originally marketed as a non-addictive chemical. So a lot of things have changed in the last 50 to 75 years. Tissue damage causes the release of the endogenous substances. This is, normal physiology, of course. Activation of peripheral pain receptors, also called nociceptors, by certain noxious stimuli may generate some of these signals that travel into the dorsal horn of the spinal cord via the dorsal root ganglion. From the dorsal horn, then, these signs are carried along the ascending pathway to the thalamus and to the cortex. And the pain, or the perception of it, can be controlled through various opioid drugs. So just kind of a recap, the pain gateway is located in the spinal cord, of course, highlighted in the white box here. S refers to the small nerve fibers, which are the A beta nerve fibers or the C fibers that transmit pain. L, capital L, refers to the large nerve fibers, and these fibers transmit sensation, touch, vibration, etc. And an I, of course, is the GABA interneuron, basically present in the dorsal horn of the spinal cord. Excuse me. P is the projection neurons that can be activated to send the pain signal to the cortex for the perception of pain. In the top panel, neither the S or the L fibers are stimulated. The interneuron is activated and then therefore releasing GABA, which will act on the projection neuron. It will then hyperpolarize on the projection neuron, and then no signal will be sent to the cortex, and thus no perception of pain will be felt. In other words, the pain gateway would be closed. Okay. Now, in the middle panel, the large nerve fiber is activated, and so remember, this is kind of your normal sensation. It activates the interneuron to release more GABA. The GABA can act on the projection neuron, hyperpolarizing it. And so thus the outcome will be no pain signal will be sent to the cortex, and then no perception of pain will be felt. Thus the pain gateway remains closed. However, in the bottom panel, the small nerve fiber is activated. The neuron synapses with the interneuron inhibiting it, and therefore now GABA will not be released from the interneuron. The projection neuron will be activated since there's no GABA from the interneuron inhibiting its activation, and then the signal will be sent to the cortex, and so pain will then be perceived. And so now we can say, this pain gateway is open. And so then just to recap, S is for the small neuron, L is for the large neuron, and then I is for the interneuron. Endogenous substances can be regulated kind of within this pain gateway. Enkephalins are released to inhibit projection cells from sending the signal to the cortex and closing the pain gateway. This is where opioids will also work. In terms of pain management, several drugs can help manage pain. Of course, the topic for this lecture is opioids, and these drugs in particular can hinder the pain signal from reaching the cortex by closing the pain gateway within the spinal cord, as well as altering pain perception in the cortex. Non-opioids, such as non-steroidal anti-inflammatory drugs, as well as aspirin, can interfere with pain perception in the periphery, but hindering pain transmission, however, they will not be able to do that, and so they're not the focus of this lecture. Opioid receptors, are dispersed throughout the body, but a few key regions are involved in the major effects as well as side effects of opioid drugs. Opioid receptors are located in the brain, brainstem, spinal cord, peripheral neurons, as well as in the intestine. The effects of opioids such as pain cessation occurs through activation of the mu receptor, and the associated side effects such as sedation, activation of the mu and kappa receptor, euphoria, activation of the mu receptor, dysphoria, activation of kappa, and constipation, activation of mu, as well as urinary retention, activation of mu, meiosis, activation of mu and kappa, and respiratory depression, activation of mu, are all possible through administration of one drug. The delta opioid receptors are throughout the body and thought to mediate emotion and behavior. When an opioid binds to an opioid receptor within the membrane of a neuron, the calcium channels close, which blocks positively charged calcium ions from entering the cell, and that reduces the release of substance P, which reduces the activation of postsynaptic neurons or projection neurons to the cortex. In addition, cyclic AMP levels decrease and potassium channels open, allowing positive potassium ions to exit the cell. These events hyperpolarize the cell, increasing the charge difference between the cell's interior and exterior environment, making the neuron less likely to fire an action potential. By quelling the activity of these neurons, opioids block the perception of pain. And so, as wonderful as opioids are in terms of blocking pain, they become problematic because they have a high abuse potential. And it's been shown, and it's been well documented and recently publicized in the media, that continued use of opioid analgesics in the absence of pain can actually lead to opioid misuse and or abuse of these drugs. So how does this occur? Or rather, why does this occur? Well, really because we see an increased release of dopamine within the reward pathway. And so how this occurs basically is demonstrated here. Basically, the opioids bind to the opiate receptors that are concentrated in areas within the reward system. And so action of opioids within the thalamus contributes to their ability to produce analgesia. And so this diagram kind of nicely summarizes opioid mechanism of action in the reward pathway. And so what you see here is an opioid binding to the mu receptor basically is going to reduce the release of GABA. And so remember, GABA is one of those inhibitory neurotransmitters. And so GABA normally inhibits dopamine release. Now, if you inhibit GABA, you're going to reduce GABA's activity, but now dopamine release is going to be uninhibited. And that's really kind of the main crux of how these drugs contribute to dependence and the reward pathway. And so let's talk about some of the various opioid agonists that exist. So in terms of analgesia and the ability to control pain, ethanol is a prime example of that. And so ethanol can be an analgesic. It's also a CNS depressant, and it also affects consciousness. Opioids, however, do not. So each opioid has different pharmacokinetic properties, half-life, side effects, bioavailability, and so forth. Codeine and heroin also have other metabolites, which have obviously various functions throughout the body. Of course, heroin, remember, is not prescribed, and so it's interesting that the half-life of these drugs is particularly short. Heroin half-life is only 30 minutes, but the duration of action may be up to 6 hours, and that's really due to these alternate metabolites that are made by the CYP P450 system that have biological activity. And so you can see some of these different conjugates having more or less different bioavailabilities and different biological activities because they also get made by the liver. And so as a group, opioids, in terms of their mechanism of action, they are direct-acting agonists of the opioid receptors, so mu, kappa, delta, and they reduce the release of substance P, they activate the pain suppression pathway, and they increase the pain threshold, which is key without affecting consciousness. And so that's kind of the unique attributes of this drug, or this drug class, rather. The side effects are notorious, and so respiratory depression is very well described. Sedative properties of these drugs are well known. They do make you tired and sleepy. Opioids are also great anti-coughing agents, and they're also great anti-nausea and vomiting agents as well. They can produce constipation, although if you do have diarrhea, constipation would be a blessing. And so there are various formulations of opioids that are administered that have a profound effect on the GI system. And they can also produce a sense of euphoria, so patients are very happy when they're on opioids. And of course, you can tell a patient is on an opioid because they will exhibit pinpoint pupils. Okay, so I think we'll end there, and we'll continue on discussing the nuances between all these different opioids.